For talk number 3, we're going to talk about shock in the cardiac ICU. So we'll start off with some basic concepts, and the first one is the definition of shock, and it's just a mismatch of oxygen supply and demand. So shock occurs when the body cannot supply the peripheral tissues with enough oxygen to undergo pure aerobic metabolism. And so this is why you see an acidosis occur. This is why you see a lactate rise. And in order to diagnose shock states, I kind of think of it in 3 pieces. The first of which is clinical signs. So is a blood pressure low, is a urine output drop. Second is hemodynamics. So usually in the CTICU, we have central lines and we have PA catheters. So you can kind of look at the different values measured, like CBP, wedge, and SpO2, and build a case of what you think is going on. And the third thing is labs and imaging. So we love ordering ABGs, love getting lactates, and of course chest x-rays, CT scans as well. We're trying to figure out why there's this mismatch of O2 supply and demand. And this is very important. I think the whole theme of this talk, right, is that shock, you can kill someone if you diagnose shock wrong. So it's all about figuring out what is the underlying pathology and then choosing the appropriate treatment. So the first type of shock we're gonna talk about is a vasoplegic shock, which is a distributive non-septic shock. Most of the other distributive shocks that we see in the hospital are all septic shock. The main difference is that all of the CTICU patients, especially when they're post-op, almost all of them have had cardiopulmonary bypass. And so what that does is when the blood goes through the bypass machine, it causes a systemic inflammatory response, which then causes peripheral vasodilation. So what we see is similar to septic patients, is that we see fevers, a hyperdynamic circulation. We also see tachycardia, but this is all driven by by cardiopulmonary bypass in the operating room. These patients are not septic. They can also be septic, but generally fresh, when they're like fresh post-op, they're not septic. And what we do, how we treat this is that most of the time, time is the most important factor. So in healthier patients, this post-op vasoplegic shock only lasts for like an hour or two sometimes up to a day. In the sicker patients, especially the end-stage renal patients, it can last up to 3 days. And how we treat this in the limited time frame that it occurs is primarily with volume resuscitation. Adding vasopressors is sometimes necessary. First line is norepi and vasopressin. Second line is epi. There's also a couple rescue drugs as well, such as angiotensin 2, methylene blue, and vitamin B12, which are rarely used but can be utilized in very severe or a refractive vasoplegic shock. So next we're going to move on to cardiogenic shock, and we're going to spend a little bit of time here because this is also unique to the cardiac ICU. And the mechanism is again very simple, right? And this is just the heart can't pump enough blood to meet the demands of the body. Like, that's it. But why the heart can't pump enough blood is incredibly complicated, and this is why cardiologists exist. This is why CT surgeons exist. This is why CT intensivists exist. Is that it's really, really hard sometimes to figure it out, partly because you can have multiple of these things happening at the same time, and you don't always know which one is clinically dominant. So we're just going to go over, I kind of separated these into 4 categories for simplicity's sake, just to kind of make a framework for us to discuss the different etiologies of cardiogenic shock. So the first one is postoperative complications, and this is a broader category that I created because this is all surgical factors and cardiopulmonary bypass factors that are unique to the cardiac surgical ICU. In terms of bypass, you get a myocardial stunning from the pump run. Patient can have some residual cardioplegia that hasn't been cleared out yet, or there can be an air embolism in one or both of the coronary arteries. There can also be some surgical factors, right? So perhaps the conduction system was damaged during surgery. Perhaps after surgery, there's a new anatomic change. Or it could also be that perhaps the patient had a failing LV, there was a mitral valve replacement, and now the geometry of the left ventricle changes and it starts to fail. And so these are all things that you kind of are hard to know without spending a lot of time in the ICU. But especially on like post-op day 0 and within the first 12 hours, some of the stuff in the OR, it carries over outside of the OR. The second category has to deal with the rate and rhythm of the heart. This is like the easiest one to understand, I think. And it's just if your heart rate's not high enough, if you don't have an atrial kick, or if you have pacemaker issues, it's going to cause a low cardiac output. And diagnosing this enables you to then think about, okay, why is there a rate problem? Why is there a rhythm problem? And that's a subject for one of the future talks. The third reason why you can go into cardiogenic shock is due to systolic failure, and that means that either the RV, the LV, or both just can't pump enough blood, and they're just not strong enough. And there could also be a new wall motion abnormality as well. This cardiac surgery, the septum of the heart can do some strange things afterwards. So again, it's this kind of out of the scope to go into all the minutia, but I think thinking in broad categories can get you pretty close to the correct answer. And fourth is diastolic failure. And this is, I think, the hardest one to understand. And I kind of think of the heart as a rubber band, in that when you pull it apart and you let it go back to its normal size, that's systole. And so when the rubber band is lax and can't go back to its normal size, that's like systolic heart failure. Diastolic failure is when the rubber band can't even stretch. So these are like very stiff left ventricles that are highly sensitive to changes in preload and changes in afterload. And so we're not going to go into the nuances of diastole, but just these are just kind of 4 broad categories. What do you think of an etiologies that can help guide your management? And the treatment of cardiogenic shock is highly, highly dependent on using hemodynamics and point-of-care ultrasound to figure out what's wrong with the heart. And we're going to talk about point-of-care ultrasound later, but just know that the treatment for this is either diuresem, give them inotropes, or give them vasodilators to treat preload, contractility, and afterload. And then if that medical therapy doesn't work, we're looking at a mechanical circulatory support. So next we'll talk about hemorrhagic shock, and I think this is kind of an easy one to understand as well, in that just when you don't have enough blood in the pipes, the body can't perfuse. Then in terms of the CTICU, what we're really interested is whether it's a medical etiology, so the patient has a coagulopathy or platelet dysfunction from cardiopulmonary bypass, and you might need to give them more products, or are they hypothermic, possibly acidotic? Once you've treated all the medical causes, then you kind of think, okay, is there a surgical lesion in the chest? And that's when you might need to call the surgeons and say, listen, I've already treated everything, coags are normal, temperature is normal, acidosis is gone, chest tube output is still high, right? We need to think about taking you back to the operating room. So that's the big thing with hemorrhagic shock and the CTICU is treat the medical stuff, and then anything left over is surgical. So the next thing we'll talk about is hypovolemic shock, and this is kind of the great imitator, is because the mechanism of this is due to decreased intravascular volume. However, other things can look like this, so just keep that in mind as we go through. The etiologies are patients who are NPO without IV fluids, patients with high chest tube output, or with excessive diuresis. And you can sometimes see arterial line respiratory variation. You can also use point of care ultrasound as well. I think hemodynamics are a little bit less useful in this situation. And again, I think the reflex is when the patient lactate bumps or they have a acidosis, is to always just give them a volume. I would just caution you that whenever you think someone has pure hypovolemic shock, you really do need to look at other etiologies and rule them out first, because cardiogenic shock oftentimes looks like a hypovolemic shock. So really look hard at the heart, and really try to prove that it's a cardiogenic, try to prove that it's hemorrhagic, and try to prove that it's vasoplegic first, before you just give them a bunch of colloid or crystalloid. And then lastly, we'll look at obstructive shock briefly. And obstructive shock means that there's some physical barrier to cardiac output in the chest. And this is usually it's either tamponade, PE, pneumothorax, or hemothorax. I think these are pretty common in the ICU. You see PEs sometimes, but it's tamponade and pneumothorax is pretty common. And the signs of this are going to be a high CVP and tachycardia, I think, are the main signs. Another clinical thing that you see is they have great temporary responses to volume and pressors. So they'll respond really well at first, and 5 minutes later they'll be back in the pressures back in the toilet. So treating and diagnosing obstructive shock, the most important thing is to figure out what the underlying cause is, and I think this is where imaging of the chest is super helpful, especially chest x-rays and CT scans. Point of care ultrasound is especially helpful, especially in pneumothorax and cardiac tamponade. So the goal is to diagnose and then either fix a problem yourself or call someone to help you. And a lot of the times, if you need to give a TPA, you're calling a pulmonologist, like a PE team. If you need to put in chest tubes, if you can't do it yourself, you're going to be calling the surgeons to help you. If you need to drain a pericardial effusion, you can do it yourself, or you can call the cardiologist to help you. And while you're figuring all this out, you can inotropes, vasopressors, and fluid resuscitation is going to help temporize the situation. So I think the key in this entire talk is to really look at what's happening to your patient, look at hemodynamic data, look at imaging data, look at lab data, and really kind of build a case. Think of yourself as a lawyer, and I have to go in front of a cardiologist, and I have to go in front of a CT surgeon and the nursing staff and whoever else, and I have to present this case in court. How am I going to prove beyond a reasonable doubt that I'm right? And what I found is having that mindset will tends to give you the best results. So finding the etiology is key. These are very fragile patients, and we really don't want to harm them by giving them the wrong treatment.